Welcome to our video on medium vessel vasculitis. Let's get started. Here's an overview slide of different types of vasculitis and what we'll be discussing in this lecture. And we'll be discussing three disease processes: thromboangiitis obliterans, Kawasaki disease, and polyarteritis nodosa. For each of these conditions, we'll cover the definition all the way down to management. And we're going to start with definition. And I'd also like to mention that this image here was contributed by Ambos. So thanks to our partnership with Ambos, I can highlight several important features of medium vessel vasculitis. And in this diagram, we introduce different types of vasculitides that are classified based on the vessel size. And medium vasculitides typically involve inflammation of medium-sized vessels. As you can see here, there's thromboangiitis obliterans, Kawasaki disease, and polyarteritis nodosa. And those are the most common diseases in this group. So let's start with thromboangiitis obliterans. Thromboangiitis obliterans is also called Buerger's disease. It's the inflammation of small and medium-sized arteries and veins in the distal upper and lower extremities. It's important to note that the affected vessels are non-atherosclerotic. This is a key differentiating feature from peripheral artery disease. Now let's talk about the risk factors. Males under 40 years of age are typically affected. Also, there's an association with Asian and Eastern European ancestry. Cigarette smoking is the biggest risk factor and the most commonly tested one. So let's move on and discuss pathophysiology. As we know, tobacco smoking is the most common trigger. It triggers the inflammatory process, which then results in deposition of PMNs, leukocytes, on the walls of the arteries and veins. And subsequent damage to the endothelium of the vessel favors this thrombus formation. And you can imagine as that thrombus develops, there's eventually going to be obliteration of the vessel lumen. In fact, as the disease progresses, leukocytes then become replaced by fibroblasts. So this causes perivascular fibrosis with thrombus reorganization. Now eventually, the end result is ischemia of those tissues involved. Let's talk about the clinical features. Now patients may present with a triad of claudication, Raynaud's phenomenon, and migratory superficial vein thrombophlebitis. Raynaud's phenomenon is defined as a color change seen in the skin going from white to red to blue. This finding is most pronounced in the distal digits, and it's typically precipitated by cold temperatures. On physical exam, nail changes, ulcerations, and gangrene accompanied with decreased ankle brachial index, and a reduced or absent radial, ulnar, or tibial pulses can be observed, and that's due to the hypoperfusion from the vascular occlusion. On physical exam, skin changes are often seen with Buerger's disease. In particular, gangrene is almost always associated. And this physical finding develops due to the decreased blood flow, eventually leading to signs of tissue decay. Notice in this image here that reveals gangrene formation. Let's now talk about the diagnostic methods for this disease. Buerger's disease is typically a clinical diagnosis, and imaging is not always required. But once imaging is initiated, you're going to start with a Doppler ultrasound. But arteriography is the best test. Arteriography reveals smooth, tapering segmental lesions. And when it's not super clear, you can say that when arteriography is equivocal, then further investigation might be considered. Ultimately, you can confirm the diagnosis with an excisional biopsy, but that's actually rarely required. So you can just think clinically, if it's not clear there, you can do a Doppler ultrasound, and then you can progress to an arteriography. And then if you're really confused still, you can do a biopsy. Now on laboratory findings, antiocardiolipin antibodies can be present. And unlike other vasculitides, ESR and CRP are normal. Let's move on to the treatment section. Patients with this disease must avoid cigarette smoking because it's the most common etiology. Vasodilators, such as calcium channel blockers, may be helpful with Raynaud's phenomenon and vasospasms. And IV prostaglandins can be of use in severe limb ischemia, can help dilate things. And local debridement with antibiotics is actually important in treating infected ulcers, which makes sense. If there's ulcer and it's infected and they're getting gangrene, then naturally you're going to want to use some debridement and give some antibiotics to help prevent infection or progression. Now, when it comes to patients with severe symptoms, such as loss of sensation in the extremities, you should consider arterial bypass, especially if the above treatments haven't worked. However, amputation is commonly required because those patients get gangrene in their extremities. and you want to prevent that outcome if at all possible. A 34-year-old male of Romanian descent presents to the clinic complaining that his fingertips turn blue and become numb when it's cold outside. Some minor nail changes and reduced radial pulse are noted on physical examination. Based on the most likely diagnosis, how would you counsel this patient to avoid progression of his condition? Okay, so this patient is a young male of Eastern European descent. He seems to be experiencing Raynaud's phenomenon, as well as claudication. He also has decreased pulses and nail changes. All of this information points to a diagnosis of thromboangiitis obliterans, or Buerger's disease. One of the key risk factors for developing or worsening of this disease is cigarette smoking. So, smoking cessation is considered the mainstay treatment of this condition, and failure to quit smoking often leads to amputation of the distal extremities. So, the key is to counsel patients about smoking cessation. Now let's move on to Kawasaki disease. Kawasaki disease is the most common vasculitis in children. This condition causes necrotizing vasculitis of medium-sized vessels, and it's actually a multi-system disease. So it's also sometimes called mucocutaneous lymph node syndrome. So based on that name alone, you can see that it's multi-system. It involves mucosa, skin, and lymph nodes. And we will discuss this detail in our clinical feature slide. Let's discuss the common risk factors seen in patients with Kawasaki disease. Now, 80% of patients are usually less than 5 years of age. Also, it's more predominant in children of Asian ancestry. So now let's talk about the clinical features. Patients are diagnosed with Kawasaki disease if they have 5 days of fever and at least 4 of the following 5 criteria shown in the slide. Clinical features included in the criteria are bilateral non-exudative painless conjunctivitis sparing the limbic area, edematous tongue with small white bumps, commonly referred to as the strawberry tongue, based on how it appears. Also, erythematous polymorphous rash, peripheral extremity changes, and those extremity changes can include induration of the hands and feet, and desquamating palms and soles. Lastly, the 5th criteria is cervical lymphadenopathy, which is greater than 1.5 centimeters, and it's usually just on one side, so unilateral, and the patient finds it painful. The images here demonstrate the key features of Kawasaki disease. Let's start with image A on the top left corner. Here we see a child with bilateral non-exudative conjunctival injection. And typically, the limbic area is spared. Next, on image B, we see an example of a patient with a bright red tongue. And that's what we call that strawberry tongue. And that's a very popular clinical feature of Kawasaki disease. Most people can remember it, and it's highly tested. But you got to keep in mind that this strawberry tongue appearance can actually be seen and diagnosed with scarlet fever, and that is caused by strep pyogenes. Now focus on images C, D, and E. This erythematous rash mostly arises on the trunk, but it can involve the perineum, palms, and the soles. In addition to erythema, desquamation of the fingers and perianal area can be seen. And you can see depictions of those on image F and H, respectively. Now take note that desquamation is also commonly seen in the palms and soles, just like that erythematous rash we were describing. Lastly, image G points at erythema and induration at the site of a previously vaccinated area with a BCG vaccine. Let's now talk about the diagnosis. Laboratory findings include an elevated ESR and elevated CRP, as well as normochromic anemia with leukocytosis. So high inflammatory markers, anemia, that's normochromic, and then high white blood cells. In addition, thrombocytopenia can be seen. Now, inflammation of the coronary arteries can result in the formation of coronary aneurysms. And because of this, an echocardiogram is highly recommended. In fact, an echocardiogram should be performed at the time of diagnosis, at 2 weeks, and then at 6 to 8 weeks after the onset of the disease. So the take-home point here is that you're very concerned about these coronary artery aneurysms in these patients. So when you think Kawasaki disease, always be thinking about an echocardiogram, and you're going to do this serially. You want to see if you can control it and prevent it from getting any worse. Which brings us to treatment. Treatment of Kawasaki disease includes aspirin and IV immunoglobulins, or IVIG. And although not used as a mainstay treatment, Corticosteroids can be given, especially if IVIG hasn't worked, or you could say in IVIG refractory cases. So your hope is that aspirin and IVIG can control that expansion of the coronary aneurysms. A 3-year-old girl of South Asian descent presents to the clinic with a fever lasting a week, a generalized rash, desquamation of the palms and soles, unilateral cervical lymphadenopathy, and a strawberry tongue. Based on the most likely diagnosis, which test is advised? How often should the follow-up testing occur? So based on the presentation, this patient meets the criteria for Kawasaki disease, which, again, are at least 5 days of fever and at least 4 of the following criteria: bilateral non-exudative painless conjunctivitis that spares the limbic area, 2, oral mucosa changes, so we're thinking a strawberry tongue, and 3, a generalized rash, which we also see in this patient, 4, peripheral extremity changes, induration of hands and feet, or desquamation of the palms and soles, which we also see in this patient, and cervical lymphadenopathy greater than 1.5 centimeters. And that would be unilateral and painful. And this patient does have that lymphadenopathy. So based on that information, we're thinking it's Kawasaki disease. So which test is advised? Echocardiogram. And then how often should you follow up with that test? Well, as we mentioned before, you want to repeat that at 2 weeks and then repeat it again after 6 to 8 weeks. Lastly, let's discuss polyarteritis nodosa. Polyarteritis nodosa is the inflammation of medium-sized vessels involving the nervous system, muscles, skin, kidneys, and the GI tract. Pathophysiology involves immune complex-mediated inflammation that actually affects all the layers of the vessel wall. Now, an important point to remember is that this disease spares the lungs. Let's talk about the common risk factors of polyarteritis nodosa. Patients infected with hepatitis B and HIV are at high risk of developing this disease. Although the association between polyarteritis nodosa and hepatitis B is well established, the mechanism behind why this association exists is largely unknown. Regardless, try to remember that because it's frequently tested on boards. This slide shows the clinical features that we expect to see in a patient with polyarteritis nodosa. They may present with constitutional symptoms such as fever, weakness, and myalgias. Narrowing of renal arteries can lead to renal insufficiency, and eventually, patients may present with secondary hypertension. Gastrointestinal involvement is characterized by the inflammation of the blood vessels supplying the intestines. And inflammation of these vessels can lead to ischemia and result in severe abdominal pain and bloody diarrhea. And that's fairly intuitive. It's kind of like mesenteric ischemia that's known as being painful to the patients who have that. Same thing here. There's inflammation of those blood vessels and they get abdominal pain. Now, neurologic involvement usually manifests as mononeuritis multiplex or stroke. Now, what's mononeuritis multiplex? Well, this involves 2 or more than 2 isolated mononeuropathies, and it's usually asymmetric and it's painful, and it can present with both sensory and motor symptoms. Now, cutaneous involvement is characterized by rash, ulcers, and erythema nodosum. And erythema nodosum is inflammation of subcutaneous fat, so it presents as this reddish, tender nodule, mostly on the shins of legs. Finally, this disease can also have cardiovascular involvement. In fact, the most feared complication is a myocardial infarction. So let's talk about the diagnosis of polyarteritis nodosa. Laboratory findings include an elevated ESR, and a biopsy is frequently used in diagnosing this condition. Findings show segmental and transmural inflammation with fibrinoid necrosis. Angiography reveals small aneurysms and stenosis. And a diagnostic feature called string of pearls is a term often used to describe the multiple small aneurysms that appear as beads on a string. So you're thinking about their vasculature, and you see these beads on a string appearance, and that really is just a series of aneurysms. Let me show you what this looks like with angiography using the next slide. Here's an image with the characteristic string of pearls seen in late-stage lesions of polyarteritis nodosa. While this finding is frequently seen in this condition, it's actually not specific. In fact, it can be seen in fibromuscular dysplasia. But the important thing to remember is why this occurs in polyarteritis nodosa. Again, it's that series of small aneurysms.
Here is an image showing the histology of polyarteritis nodosa. Notice that the arterial lumen is surrounded by fibrinoid necrosis and transmural inflammatory infiltrates.
So here we can see an image of the kidneys. And this is a patient with polyarteritis nodosa. And notice that formation of microaneurysms, obviously here within the renal vasculature. And once again, renal involvement is very common in polyarteritis nodosa. So let's talk about the treatment of this condition. So it usually begins with high-dose steroids in order to reduce inflammation. And cyclophosphamide is often added if it's a severe case or if it's refractory to those steroids. Now take note that antivirals are indicated if an underlying viral infection, such as hepatitis B, is also present. Now let's do a board-style question to wrap this up. A 2-year-old male whose parents are Vietnamese immigrants is brought to the clinic with a history of a fever for the past 6 days, a generalized rash, bilateral painless conjunctivitis sparing the limbic area, unilateral cervical lymphadenopathy, and a strawberry tongue. The patient is diagnosed with Kawasaki disease, and the treatment is set to begin. Which of the following would be a contraindication to using the most common medication in the treatment of the underlying disease? A. Recent tetanus vaccination. B. Recent flu infection. C. Coronary artery aneurysms. D. Recent travel outside of the country. Or E. Exposure to cigarette smoke. Okay, now this patient meets diagnostic criteria for Kawasaki disease. In fact, it's so obvious that even the question stem states that this patient was diagnosed with Kawasaki disease. Okay, so now that that's established, let's talk about treatment. Now, one of the mainstays of treatment for Kawasaki disease is high-dose aspirin, which is known to cause Ray's syndrome in young children recovering from a viral infection. Therefore, the correct answer is B, recent flu infection. So we'd want to avoid giving aspirin to a child recovering from a recent viral illness in order to avoid that complication of Ray's syndrome. So in this patient, the treatment would most likely be limited to IVIG. Now, answer choice A is incorrect because a recent tetanus vaccination does not contraindicate the use of aspirin or IVIG. Now, answer choice C is incorrect because coronary artery aneurysms are a possible complication of Kawasaki disease, but their presence doesn't contraindicate the use of aspirin or IVIG. In fact, it's their presence that is really what you're trying to prevent or prevent from worsening with aspirin and IVIG. Answer choice D is incorrect because recent international travel could be a contraindication to using strong immune suppressing medications, but it doesn't contraindicate the use of aspirin or IVIG. Answer choice E is incorrect because exposure to cigarette smoke is a risk factor for thromboangiitis or obliterans, but it does not affect the efficacy of aspirin or IVIG in this patient. And that concludes our video on medium vessel vasculitis.